inpatient settings. In addition to acute care, short-term care, and long-term care hospitals, the definitions for principal diagnosis and other secondary diagnoses also apply to psychiatric hospitals, home health agencies, rehab facilities, nursing homes, and other settings. So you're going to find that we're getting ready to discuss in detail, for instance, what the principal diagnosis is. There's that first line, that definition we've already talked about. The condition established after study to be chiefly responsible for admission of the patient to the hospital. You've got to designate it correctly because it's very significant in cost comparisons. All right, Hospital A. I'm going to have to write this down so I don't get confused myself. Hospital A has a patient with pneumonia, influenza, and a CVA, or a stroke. Hospital A puts down the principal diagnosis of pneumonia. That patient's costs, were $50,000. Hospital B has a patient with pneumonia, influenza, and CVA. The very same thing. This time, they put down the CVA as the principal diagnosis. And they charge $75,000. Hospital C, guess what? Same diagnoses, pneumonia, influenza, and a CVA, only this time they put down influenza as a principal diagnosis, and they charge $60,000. Aren't the patients pretty much identical as best we can tell with the information that we have in front of us?
Yes.
Well, can you figure out why there's such a variation in charges?
Somebody wasn't understanding, or they were trying to get the one that pays at least the most.
All kinds of explanations. None of them really tell the whole story, do they? Okay, but because in that instance, the hospital just chose what they wanted as a principal diagnosis. If, however, each one of those was using the definition of principal diagnosis, and let's say that each one of them, as a result of that, now had the CVA as the principal diagnosis, what are you now looking at and thinking about when you look at the data for costs? They all had the same problems. They all had the CVA as their reason determined after study to be the reason for admission. But one hospital charged $50,000, one charged $60,000, and one charged $75,000. What's going to come to your mind? If one hospital can do it for $50,000, why didn't the other two do it for $50,000? All right, poof, I've just made you the president of an insurance company. And your insurance company has covered each one of those three patients. And you're sitting there and you've got a bill for $50,000, $60,000, and $75,000 for what appears to be identically the same patient with identically the same care. What are you going to say as the president of the insurance company? I'm going to pay for it, but how much am I going to pay?
To Lois.
I'm going to pay you all $50,000 because if one could do it for $50,000, you all could do it for $50,000. All right, from that, are you just beginning to get a little bit of taste about how coded information is used for lots of different reasons? Oh, yeah. And one of those reasons is to compare costs among healthcare providers. I used to be a Blue Cross rep. I had 25 counties. I knew where I could go get a urinalysis for $2, and I knew where I could get a urinalysis for $25. It was the same pee in a cup, ladies. It didn't matter. It was the same procedure. Now, why would an insurance company pay one doctor $25 for a urinalysis when other doctors were doing it for $2, $5, $7? Would they necessarily pay? No, they wouldn't necessarily pay. They might say, okay, well, we'll give you $3 toward that $25, and you'll have to get the rest of it from the patient. Oh. So does that begin to affect your pocketbook? Are you a conscientious health care shopper? Should you be? Yeah. Yeah. All right, I want to introduce something that you talked about with me in HIT 110. Do you remember reading about medical tourism? And what is medical tourism?
It was about the story when the lady, when you could have surgery somewhere else in another country for cheaper. The employee was paid what they gave you incentive.
That's right.
To go out of the country to get the surgery because it was cheap.
That's right. So you mean I could have a coronary artery bypass graft, a cabbage, and I could go to India and have it done. It would cost my employer half of what it would cost in the United States. And on top of that, they could send my husband along with me, and they could give me $10,000 cash. Now, if that's the case, how long is it going to be before every insurance company begins to say, yes, we'll be glad to pay you to go to India or Mexico or England because we can save big bucks and still fly you over there and still let you stay in a nice hotel. You see what I'm saying? Well, think about it. And having talked about it in that class, 2 of our classmates had medical tourism before. One of them had been to Brazil for a bypass, a gastric bypass. The other's spouse had been to, I think, Ron's wife had been to gastric bypass in Mexico. Now, they had stayed in Texas, and the bus had come and gotten them. It was in Juarez, Mexico, and took them back over to Mexico, where she had the procedure much cheaper than it would have been here in the United States, because apparently they didn't have insurance to cover it. And so, and I've had it done in the last year and a half, and so I can tell you that my hospital bill was $37,000. Now, I have state health plan coverage, which negotiates with the hospital, and they negotiated it down to $26,000. But that was $26,000 for 2 nights in the hospital and 1 surgical procedure. That did not count the amount to the doctor. That did not count the amount to the anesthesiologist. That did not count the other preliminary things. All right, all told, because I had insurance coverage, I probably had $2,000 out-of-pocket costs. So it wasn't necessarily beneficial for me to think about going out of the country. But if I had had no insurance and I wanted that procedure done, I could have either paid the $37,000 here, or I could go to Juarez, Mexico, and paid maybe $5,000 or $3,000. So do you see how medical tourism becomes very important? So it's not only costs directly to the patient, but it's also cost to the health care insurer. The state of North Carolina went like $200 million in the hole last year for state employees' health care coverage. They're already projecting that our health care coverage is going to cost us an additional 30%. Okay? An additional 30% to try to offset that. So are you going to be involved in looking at health care and what it costs in your future as an RHIT? Oh, yeah. Oh, yeah. You'll be, that's one of the things that you'll be doing, is looking at trends of health care, costs of health care, how can we get health care down, the cost of it, and that sort of stuff. And part of that is by knowing all of these intricacies. All right, principal diagnosis. You know that definition up one side and down the other, because I promise you, you're going to have to. It is important that the principal diagnosis be designated correctly because it is significant in cost comparisons, what we just did. In care analysis,